So thank you once again, and thank you for the opportunity to present another interesting case. This one is, again, a case of transcatheter closure of paravalvular leak, but this time after a TAVI procedure. This case involves a 26-year-old male patient with a medical history of hypertension, type 2 diabetes mellitus, atrial fibrillation, and severe symptomatic aortic valve stenosis, which was treated in our department in February 2023 with the transcatheter implantation of a 29 millimeters Medtronic evolutar bioprosthetic aortic valve. As we can see here from the pre-implantation CT scan, the native aortic valve was heavily calcified with calcium not limited to the valve leaflets, but extending into the aortic annulus and the left ventricle outflow tract, particularly in the region between the left and non-coronary cusps, also clearly illustrated in this three-dimensional reconstruction. You can see the extension of the calcium into the left outflow tract. So predilatation was therefore performed pre-TAVI, followed by the deployment of the bioprosthetic valve, as you can see here. However, due to clear evidence of paravalvular leak on angiography post-deployment, balloon burst dilatation with a 24 millimeter balloon was carried out. This resulted in mild improvement, although a moderate paravalvular leak persisted, as you can see. During close follow-up after the procedure, the patient remained clinically stable with mild dyspnea, and serial echocardiographic evaluations consistently described a moderate to severe paravalvular leak, while left ventricular dimensions remained within normal limits. However, from September 2024, the patient experienced a deterioration in functional status with worsening dyspnea. In response to this deterioration, a new transthoracic echocardiogram was performed, revealing mild dilatation of the left ventricle with preserved systolic function. There were no signs of stenosis of the bioprosthetic aortic valve. However, the paravalvular leak was confirmed and classified as severe based on the size of the regurgitant jet, the measured pressure half time, and the presence of holodiastolic, as you can see here, the pressure of holodiastolic flow reversal in the descending aorta. Moderate mitral and tricuspid regurgitation was also observed, along with mild pulmonary hypertension. A transesophageal echocardiography was subsequently performed, which allowed for better visualization of both the extent and the precise location of the paravalvular leak, situated between the left and the non-coronary sinuses, as seen here, and more clearly here with magnification and 3D imaging. The next examination performed was the CT scan, which, as you can see, provided us with additional information regarding the shape, the length, and the width of the tunnel, and the calcification in the area, all of which are crucial for optimal management. Based on all this, and taking into account the patient's history and age, the heart valve team of our hospital decided that transcatheter paravalvular leak closure should be the optimal strategy. So, as I said earlier this day, in general, there are two main devices available, the Amphitheatre vascular plug 3 and the Occlutech paravalvular leak device. The second one is available in square and rectangular shapes and in two configurations, with waist and without, called twist. And the second one offers greater flexibility in irregular or classified defects, while the Amphitheatre vascular plug 3 is better and adapts better to smaller round leaks. In our case, based on the crescent shape, the rather narrow and surely classified tunnel, we chose the twist device by Occlutech, and the size was based on echocardiographic measurements taken during the procedure. These are in short the steps of the procedure. The procedure was performed under general anesthesia with TOE guidance, and vascular access was obtained via the right femoral artery, through which 6 French, 9 French, and 10 French introducer sheaths were sequentially inserted. An initial attempt to reduce paravalvular regurgitation was made by balloon dilatation of the valve using a NUMED 25 to 40 millimeter balloon. However, due to the persistence of significant regurgitation, as you can see, the decision was to proceed with paravalvular leak closure. Initially, we managed to cross the paravalvular leak with a straight wire through an AL1 6 French catheter. But AL1 itself could not be advanced through the tunnel of the leak, as you can see. So we overpassed this problem with the mother and child technique, which means that we advanced through the AL1 guide catheter, a longer 5 French multipurpose catheter, which was able to be advanced further into the tunnel and the NV, as you can see here. The straight wire was then removed, and the Landerquist wire was advanced into the left ventricle. Subsequently, a Nocultec 5 French sheath was inserted via the right femoral artery, and then the device was advanced through the sheath, and the first disc was extracted into the left ventricle. The entire system was then retracted until the first disc reaches the outflow tract of the leak. And then the twist segment and the second disc were deployed. After confirming the stability of the design, an angiography through the sheath was made, showing persistent regurgitation, as you can see. But an increase in diastolic aortic pressure was observed, and the echocardiography also showed reduction of the regurgitation jet, so we decided to release the device, as you can see here. And this is the final angiographic result. The patient remained stable, and his hospitalization was completed uneventfully. And at the scheduled 1-month follow-up, despite the echocardiographic evidence of residual paravalvular leak, as you can see here, the patient reported marked clinical improvement. And he says that he is now able to walk up to 500 meters, corresponding to an improvement to a NIHA class 2. So in conclusion, paravalvular leak is a relatively common complication after TAVI, and one of the most important anatomic risk factors is severe annular calcification. In our case, the patient had extensive calcification, which likely contributed to PVL formation. Fortunately, percutaneous closure was rather successful, and the patient experienced significant clinical improvement at follow-up, despite the presence of residual regurgitation. This case highlights the importance that PVL closure is a safe and effective option in selected patients. Thank you for your attention.
Thank you, Dr. Perlepe, for your excellent case. The first question is, do you think that a paravalvular leak is because of the calcification, or the valve was deeper inside the left ventricle?
No, I believe that this was because of the calcification, because as you saw, the leak was exactly in the region of the calcification that we saw before TAVI. So I think that this is the reason.
So because of the position of the valve?
No, because of the calcification.
For the calcification?
Yes, yes, clearly.
And for this reason, you decided to have a leak.
Yeah, it was heavily calcified, as you could see in the initial thrimensio. So it was we expected in the initial procedure to have some leak, but we did pre-dilatation. We were really modest because we were aware of the calcification extending at the LVOT, and we were afraid to disrupt the annulus. And this case is very similar to the initial case that the case that Dr. Pilates showed us yesterday. So he had a similar expansion of the pre-dilatation balloon. The left cusp was never been properly approached by the balloon. So so he ended up rupturing the aortic annulus. So this is something that would always pay special attention, because it's something that maybe you cannot get away with it. But definitely there was at least moderate AI. So at that time we checked, and it was the AI index was 28. So we left it alone. But as in the next year, in the next follow-up year, you will see that there's deterioration of the clinical status of the patient. So we need to do something. And I think that this is a good approach. We need to be able to tackle these cases and maybe not be afraid to place a plug when there is a need to be placed. Dr. Kalogeras.
Congratulations for the case.
I'm sorry. Please, microphone.
I think it's Evoltar.
Evoltar. Yeah, would you think because of the massive calcification, a pro would avoid this happening initially?
Yes.
Because it was a perfect landing height, so obviously the calcium was the problem. So probably the pro would be better for that. And
probably, but we don't know. Yes. we saw also in pro as well. So.
And another issue, because I want to share with you a similar case we had in the lab, and trying to, because it was just a few months after the initial implantation, trying to cross the leak with the sheath and the liver sheath was quite risky to embolize the device. So we kept with a snare the whole valve in order to avoid migration or embolization of the valve towards the ventricle.
Of the valve, yes. But after 1.5 years, I don't think it would be really, maybe. And with such a huge calcification, I don't think that the valve was pretty stable. So, Vasily, you were asking about the technicalities of the.
I think that this may happen because the valve, because of the calcification, is not stable and sometimes move. I don't know if you have signs. And another question on technical view: do you need that? You need to have a transesophageal echo. You had also, yes. Because yes, it's very, very important to.
We did the measurements initially at the procedure.
Dr. Mezilis.
The correct size, and we are giving constant guidance during the procedure.
It was a great case. I want to ask you a technical question, or if this is very important or not. When you cross the wire, do you check that you are outside the frame, or you go in and out? Does this make any difference to the way that you deliver your plug? Because I guess in this case, the wires seem to be outside the frame.
Yes,
but sometimes you can go in and out.
Yes, but
then you might interfere
we check
with
multiple projections and also with TOE, which is very important, as Dr. Voudris said. Yes.
Maybe Dr. Kalogeras remember a case. We implanted the valve. The patient, 3 months later, presented acute pulmonary edema. It was transferred. It entered in the emergency department of your hospital. You try to put...
Yeah, that's a case I mentioned before.
I know this. Unsuccessfully.
Unsuccessfully. We couldn't
and finally,
cross
the patient is operated and had valve explanation.
Exactly.
Finally, he died, not from cardiac problem, but for intestine hemorrhage. It may happen. Okay, thank you, Dr. Perlepe.